bypass with a 17-year continuous follow-up. And so you don't see that much in university settings. We talked about the nomad professors who, in order to achieve up the hierarchy, work their way up the ladder, they have to move from place to place, and so they don't have follow-up. So we presented recently a case with 40-year follow-up. That's a gentleman with 17-year follow-up. So it gives you a glimpse into longevity cardiology, longitudinal study of cardiology, rather than these little snapshots. Personal experience with one of my patients. So we'll tell you a little bit about this gentleman. If there's any questions you have, feel free to interrupt me. This gentleman was 69 years old when he first came to my office, and a woman who was originally from Kentucky, and put over Kentucky Explorer magazines. And so if he was coming every 6 months, I got 6 months worth of Kentucky Explorer magazines, which was all about the history of Kentucky. And so that was our link. It's always nice to have a contact point with a patient. Sometimes you really, and that results in a good bonding experience. What you're going to need if you're going to have a long-term 15-year follow-up. So you have to have some relationships. And so the gentleman became a friend, and we are pretty good friends. He went to St. Joseph's Hospital in 1999 for some left arm pain, apparently a positive stress test at that time as well, and got a diagnostic cath that showed what's considered severe disease, that is almost included, which means 99% right and 95% left. 10 out of 10 cardiologists will agree that this patient is a candidate for surgery. And so, unfortunately, that's what we did. Unfortunately, in that I'm not a great lover of bypass surgery because it pretty much is like Russian roulette. I never know what's going to happen to the patient because the environment is so uncontrolled after bypass surgery and during recovery. And all that is very, very complicated and very uncontrolled. There's post-op and there's post-op bleeding, and it's so much easier to do a stent and the patient goes home that day or the next day. So here we are with bypass surgery. It wasn't done in those days for the main left, and so especially an unprotected main left. So we had no choice, and the patient's been followed by me. I guess there were 4 to 6 months during that time, and at that time we had scans, and we'll talk more about that in just a minute. So the patient was in our clinic, had some shortness of breath, some PND, some weight gain, and I'm not sure why he was having what appears to be congestive heart failure. We had a BNP then. We were the first hospital in the country to be using BNP clinically, and we were doing the BNP, and the other hospital, St. Joe and Tampa General, would see this number and wonder what it was, and so we had to post information about the BNP website so the other hospitals, Morton Plant, could come online and figure out what we're doing. They didn't understand it. And so we listed all the patients at BNP, anonymized them, and talked about the results of the BNP and what it meant. And so it was very helpful to get BNP introduced into the Bay Area. And so here, gentlemen, during this time, there was a move to do nuclear scans every year on patients who had surgery, especially if they had some symptoms. This gentleman did have some symptoms, so he got an Adenosine SPECT scan. Adenosine is basically a coronary vasodilator, increases the coronary blood flow about 4 times normal. But then if there's a fixed stenosis, that won't increase 4 times normal, and you'll have a differential to be relative. There'd be a relative decreased perfusion in an area attended by an 85% or 90% blockage, and in the other areas there would be increased perfusion because there was a blockage, and that's how you'd find the blockage. And so this patient had normal feeling of, it says exercise, it wasn't exercise, the normal flushing that occurs with adenosine with vasodilatation, and he had some images. SaO2 goes up with adenosine, that's always interesting, went up from 93 to 97%. and his blood pressure goes down, and it usually goes down with adenosine, and all the heart goes up. And you can see here the heart rate went up about 8 beats per minute. So there were no arrhythmias, surprisingly. There were some ST and T wave changes during the infusion, uncommon, and the QT interval prolongs. So let's go over here and talk about his history. It has, like everyone else that I see who has coronary artery disease, usually has hypertension and usually hyperlipidemia by definition almost, and about hyperlipidemia. And he had some GERD. He was a very heavy gentleman, so he had obstructive apnea. And he came out by having coronary disease genetically because of his father having coronary disease, mother with diabetes, and was a non-smoker, but a very sedentary lifestyle that basically resulted in his increased girth. And these are the drugs he's taking. At that time, it wasn't known that vitamin E is contraindicated if you're on a statin drug because it actually keeps the HDL from going up on a statin drug. And so physical examination showed blood pressure was okay, heart rate was okay, and had some pedal edema. And this is something important because it's going to keep coming up in this gentleman. And so this was, I guess, about 2000. And so that's basically, he did have an Adenosine SPECT scan, which we'll talk more about how we control these studies and what was the problem and what became on, and then how we evolved into PET scanning, and then how we evolved into CMR, which is the MRI. So SPECT was okay. We put him on Roxolin and Lasix and trying to get rid of the pedal edema. And follow up, and he still had some trouble with the diet for some salt restriction, which was done then, which recent data has shown that salt restriction is necessary and actually probably is a worse thing to do in patients with congestive heart failure. And the patients on salt restriction did a lot than weren't on salt restriction. So this is pretty good for the care assure people because salt restriction has been the hallmark of congestive heart failure. And a lot of doctors will see a patient that comes in and a patient in congestive heart failure. The doctor will get the patient to admit to basically eating some potato chips at night or else having some Campbell's soup. As we found out with the CardioMEM, it's not true. And there's no correlation with the salt accumulated diet that the patient is on. There's no, and violating that diet by eating a can of Campbell's soup that's high salt, there's really no correlation between that and it's congestive heart failure. And the congestive heart failure began 30 days before that, and you can see that gradually increasing pulmonary artery pressure, which reflects diastolic pressure. So we found out a lot of things have been destroyed that were considered very, very important. Salt restriction in congestive heart failure, no, patients did worse. And yes, he's here because in congestive failure had too much salt last night, not true. So the CardioMEM shows that, and that's why we're going to talk more about CardioMEMs. We'll have our CardioMEMs lecture coming up on June the 3rd at Memorial Hospital. So I hope you can make it a point to attend because that's a revolutionary change in managing congestive heart failure and has been one of the destroyers that we've had. And now we're what to do next, and we don't have our student, but we got Hassan. Hassan, what do you do next in this patient? Are you there, Hassan? Hassan's probably talking to someone right now, so let's go on and we echocardiogram and we in the queue. But abnormal septal movement, open heart surgery, so that's sometimes confused with septal damage. Apical akinesis is not normal post-open heart surgery, so that reflects what's happening with the lima to the LAD, and then there's infra-wall akinesis, not sure what was going on there. The lateral wall was beating well, the RV systolic pressure was a little elevated, the left atrium was a little large, and there was some mitral regurgitation. I'm not sure what this means in perspective, but let's go. So We thought we'd tell you a little bit about cardiac SPECT because that was the next step in this decision making. And our cardiac SPECT, we started doing those in 1990, and before that we were doing the planar imaging we set up was at Tampa General. It was the first kind of imaging that was actually built to do that at Massachusetts General Hospital into Tampa and help us set that up. We've always used the best experts we could whenever we got involved in something new. So we set that up in planar images, and the industry evolved to doing cardiac SPECT, which was a lot more expensive and imaging, but could see things that you couldn't see because it was more 3D than 2D. So it was more useful for the lateral wall. Seemed to be about the same for the LV and for the right coronary, but for the circumflex, it was more discriminating. We said, well, we're going to get into that. And so, so basically, we're going to start a new service, which was going to be at Memorial Hospital. And so we planned it from the beginning, where we're going to have a hot lab. We want to get a clean line coming in from the transformer to the scanner, so we have noise on the line. And so no other equipment was put on there. We couldn't have another piece of equipment even next to the scanner, like on the other side of the wall, because of electromagnetic contamination of the images. So we had a dedicated anchored camera released. It was right next to the treadmill. And then on the other side was the echo machine. So we basically echo on one side and nuclear on the other side, and the reading room across the hall, lab for the isotopes across the hall. And so everything was really nice and compact. So with that, we were able to get the isotope, bring the isotope in, exercise the patient. We could actually do echoes and nuclear scans side by side of the same patient and use that to critique our discrimination. And we found the stress echo more accurate in the right coronary, the cardiac SPECT was more accurate in the circumflex, and the stress echo and the SPECT were the same in the LAD. And we did 100 cases with the echo and the nuclear scan during exercise on the same patient. So we had a physician present during the entire study. We had a tech who had years of experience with the SPECT, and so she knew more than I did at the time, and we learned together. And we had the patient position was duplicated with markers, with lasers, so that the patient wouldn't move between doing the stress study and the rest study. Quiet music was played during the acquisition. The patient was actually enshrouded with a sheet to keep them from moving during the procedure. The breasts were taped up during stress and rest in the same position. Patients who, if they were males, were put on their stomach, first imaging, and those prone images get the stomach away so it doesn't interfere with seeing the inferior wall. We really were priding ourselves on the discrimination of this procedure, the resolving false negatives and false positives by getting follow-up with CAT. The radiation exposure was a little high at 22 millisieverts. That light was a little long. We were using an isotope called thallium, and thallium actually had two peaks. It had 740 keV, so we had to decide which peak that we wanted to scan and look at. And so there were two peaks of the radioisotope in terms of the energy level of the photon that was given out to make the picture. And then the SPECT scanner would move around the patient, stop, move, for 45 seconds each motion, acquiring images. And so that gave us a dimensional image as opposed to flatland and planar images that we had before. So you can see it was very complicated what we were doing. We did have one patient afterwards didn't feel good, and I saw the tech out of my car taking the patient to the restroom and then coming back, and I said, what's going on? She said, he didn't feel good, and I ran down the hall, opened the restroom, pulled him out because he had had cardiac arrest, and that was the only complication. He'd had a stress test. That was the complication, and we brought him back, and he did well. And so that's the 1 in 25,000 patients that will usually have from cardiac stress. And because I was there, he didn't have a mortality because they knew there was something wrong. And so there's a lot of convenience involved in this being a procedure involving the doctor and the tech on a continuous cycle throughout this 3-hour procedure where you would inject one isotope, make pictures, and then have the patient come back and inject another isotope and compare stress to rest and have to have the images acquired exactly the same. So very difficult thing. After exercise, the heart, because you're breathing fast, jumps and drops down, and then as you slow down your breathing and you're lying supine, there's an upward creep where the heart actually comes up. And so you can't take pictures while the heart is coming up like that from a lower area. And so you've got to wait for the upward creep to go away. And so this is all very, very technical, very involved, and very cerebral. And we're great imaging correlating them. So I'll tell you more about that in just a minute. Adenosine caused vasodilatation, and we made these images in this gentleman, and you can see that he had he was okay, and we can show you his SPECT scan, which is stress at the bottom, and what you do is compare these images from a relative defect and see if there's anything normal comparing one to the other. So we compare your rest is a normal perfusion, and you figure to induce ischemia and perhaps even induce left ventricular dysfunction. And so these images all kind of look the same, but they're done in 3D, and this has gone through a computer processing. And so if there's an artifact in here, the computer will sort of round it out, smooth it, and you won't be able to tell it's an artifact, and it'll look like a real defect. And so there wasn't an opportunity to actually view the images as the camera went around the patient. And that was a cine mode, to see if there was any jumps in the motion of the patient, moving or coughing, or having extra heartbeats, and see if there's any artifacts produced. So we got this down to a really tight science, and then we were correlating it with the anatomy from the cardiac cath, and we were pretty good. We were really getting results that were very accurate and reproducible. And but then I need to tell you there was a change made, and the change was like a coup, where basically radiology were dominance of this procedure, because we had a partnership with the hospital and the cardiologist, and we were general partners with the hospital. I was, and the other cardiologists were limited partners, and because of the Stark law, we had to round that down and close it out. And so we did. So then everything in the center reverted to radiology contract. And so the radiology then took the camera, moved it to radiology, got rid of the special tech, and assigned a general nuclear tech. And so we lost our special tech. She went off to Clearwater and took over responsibility for 3 times the size of what we were, with a doctor's office that had 3 SPECT scanners. And so we lost our intellectual capital. And then the radiologist changed the isotope to technetium, so the treadmill could be left in cardiology, but the scanner would be in radiology. But we couldn't use thallium then because the patient's isotope would be decaying so rapidly, and they'd have to get over to radiology to get their pictures. And so that would take too long if you're going to have the treadmill one place and the scanner another place. And so, so the isotope was changed. The breasts weren't taken up anymore. The prone images weren't acquired. The cardiologist wasn't there anymore. And there was no comparison to cath. And they played rock and roll music instead of quiet music. And the patient moved. And prone wasn't used. Some of the cases were read by the radiologist. There was no delay in making pictures. And the radiation exposure dropped to about 4 millisieverts to 18 millisieverts. And that's how we came up to 40% false positive, 65% false negative. It was a much shorter half-life on the isotope with technetium compared with thallium, much shorter half-life. And so we didn't have the problem of when somebody went into a bank vault 2 days later that they'd set off to an indicator in the bank and the alarm would go off and everybody come running in the vault. And so at least we avoided that. So new isotope technetium. And so we had the scan, and here's the scan, which you can see is identical. You can see that there's some problem in the inferior isotope in the inferior wall, and that's very evident over here. Is that ischemia? Well, no, it wasn't ischemia. It was the stomach getting in the way on a male, and this that you get, where there's a change here from inferior wall at rest to inferior wall during stress, and that change was because of the stomach getting in the way. And so that's where prone images were helpful. So this is a false SPECT scan, but if you look at the acquisition images before they were computer processed, computer garbage out, you'd be able to see there's clearly an artifact produced by the stomach getting in the way. And motion as well. Ejection fraction dropped, and that would be read, unfortunately, as being abnormal by the radiologist, but it was produced by the PTs, and you had to be able to monitor whether there were extra heartbeats or not being monitored when the patient was separated between cardiology with the stress test and radiology with the nuclear scan. We had to come up with a solution, and so our whole imaging procedure was disrupted by the change in contractual responsibility for scans. And so this gentleman, further talk about him, he occluded, this is when we started doing CT scans, and we started that in 2004 using 16-slice scanners. This was in 2005, and you can see a scanner, you really see a barrier to entry that you had to have a 64-slice scanner, because you look, we've got all the information we need. We can see the saphenous vein is open to the obtuse marginal, saphenous vein to the right is open, and the lima was occluded to the distal LAD graft. And so if the lima is occluded, that usually doesn't occlude, and there's a 95% patency rate at 10 years. It was a technical problem at the time of surgery, and it's usually the distal anastomosis that's the problem, and so that didn't hold up. So that was probably down the day after surgery. We did do a study once of 77 patients within a month of surgery, found that 15% of the grafts were down, and so that's not unusual either. And so what we did next to this gentleman, and next we did a PET scan. And so basically this sort of segues into how we did the PET scan and why we put PET scans in place. And, well, you saw the dumbing down of scans and how this procedure collapsed for us because of loss of contract and the dominance of the radiology contract then was lost. And so then we had to come up with a counter for that. Our counter move was to use the PET scanner that was already there in place and start doing PET scans. Well, the hospital it took a while to get them interested in it, but when they found the first about 4 times the SPECT scan, they jumped on board with a lot of encouragement from me. So we hired a special tech who was trained at Yale by France Wackers and who had a great deal of experience. And so now back into increasing our intellectual capital and not having someone who is a usual tech that really doesn't take an interest in the patient, who may be a body flopper. So we made a big move back to intellectual capital. And then during the PET scan, there's a CT scan that's done first before the PET scan. It's like a 4-slice scanner, and it's to be used to correct for any artifact that might be interfering with the photons coming from the isotope in the heart to get to the detector surface. And so if you're very dense and the proton goes through bone, there will be less photons that come out the other side. And if your stomach's in the way, there will be less. And if your lungs in the way, there will be more. And so that gives the homogeneous images, or heterogeneous. And so then the idea was, if we can do a CT scan and all those areas and measure anything that the isotope photon has to pass through to get to the detector as it's passing through the body, and be able to measure that. And then if it's passing through the lung, there's going to be brighter images in that area, so we down and adjust that area based on the Hounsfield units that the beam has to traverse coming from the inside of the heart from the isotope that's emitting photons. And in this case, it's not emitting, it's emitting photons as well, but it's a positron emitter. Positron travels a couple of millimeters, maybe 10, runs into an electron, annihilates, and gives off 2 photons, 180 degrees, separate from one another and going in opposite directions. The photons were very powerful, and a lot more powerful than the photons that we're getting from thallium. The thallium was 70 and 140 keV, and the technetium was 120 to 140 keV, and it turned out that the PET was 511 keV. So we've got more powerful gamma rays that are being emitted in the form of photons, and those therefore traverse the body better, and where they're attenuated, we can turn up a picture if it's going through bone and make that picture brighter, because it's going to be less bright because it went through greater density. When it goes through lungs, we can turn it down and try to make the image homogeneous, and that's the way this does. And so it was a very expensive technique, because rubidium is a very expensive isotope. It costs $1,000 a day, and you'd buy 30 days worth, which is a generator that had cost $30,000. Reimbursement was excellent, and there's pass-through for the isotope from Medicare, and so that wasn't a problem. And the insurers also didn't make it a problem. The radiologists were no longer reading it. We had much greater accuracy. We couldn't do a treadmill stress test, because by the time we got the patient into the scanner, the radiation will have dropped, and you'll have half as much in 72 seconds as what you had before in terms of isotope. Also, the tech would be exposed, and you couldn't use that same tech the same day. You'd have to have another tech. And so we had to go entirely to chemicals, which would be adenosine, Lexiscan, and Persantine. And so that's what we did. And so this Persantine, the advantage Persantine, is the heart rate doesn't increase much, and so it only increases about 5 beats per minute. And see on the particular patient, it decreased, the blood pressure dropped, there was some PVCs, and no reverse. And I've shown you some PET scans before, and you've seen the images, and so the images were a lot more crisp and a lot cleaner than the images that we had with the SPECT scan. So that's how we switched, which was a huge effort and very expensive, but the hospital was worth it, and we would have to save patients up to front, and then we'd have 30 days on, and then we'd have another 6 weeks off, and then 30 days on again. And so if patients in the ER with chest pain, we could bring them in as well, because we had an unlimited supply of isotope for 30 days. Questions about the difference between these scans, please feel free to me. And so this is following the patient with PET scans, and we were repeating PET scans, looking to see if there's any change, because ejection fraction went up from 50 to 70%. Ejection fraction dropped by 12% or greater, consistent with main left coronary disease. But it looks like we were doing pretty well, and this images were so superb. An area of ischemia involving a small diagonal vessel, which was really that we could do that. And so we kept doing years. It's much lower isotope exposure in terms of radiation. 1/7 of the radiation from the SPECT scan. We could pick up a lung nodule and follow it as well. This gentleman also had some evidence for atherosclerotic emboli in his right eye, but it didn't affect his vision. And he had some mild carotid disease, sleep study, it was important. And so we continued following him with routine follow-up. He was not any chest pain or any problems. His EKG this, and I don't have anybody to read the EKG for me. If Largo would like to look at this EKG, are any of the fellows available or residents from any of the programs that would like to read the EKG? Anybody over there at Largo? Guess you don't have a mic. Okay, anybody at Bennett Point would like to look at the EKG? Okay. So let's go on then with this EKG. And the EKG shows new onset atrial fibrillation, as well as some premature ventricular beats or some ectopic ventricular beats, and poor airway, and that's pretty much it. So new onset atrial fib caused this gentleman to get into breath, and so and that's not uncommon in somebody like him who has long-standing hypertension, and it was left with hypertrophy and diastolic dysfunction. So if he doesn't have that atrial kick given during normal sinus rhythm, he may lose 20 to 30% of his cardiac output because of his diastolic dysfunction. So he has done that, and so the gentleman is very short of breath, very happy. He can't go to the mailbox to get the mail without being very short of breath. No chest pain or anything else. And so usually when somebody like this has been stable for so long, since at least 2000, 2001, bypass surgery in 99, and there's got to be something new. And of course, you know, we did the EKG and find out what was new. We found he has new onset atrial fibrillation, must have some mitral regurgitation, must have some left atrial movement. People with hypertension, atrial fibrillation, that's the most common cause. And of course, during diastole, if you have hypertension, the left ventricle is going to be thickened, and there's going to be delayed filling because it lost its elasticity. It's not compliant. And so for each milliliter that's brought in, there is some resistance to that coming into the heart in terms of new volume into the heart. And that resistance is because the heart muscle isn't filling well because it's very markedly thickened. Elasticity. And so that's what's going on in this gentleman. So we said, well, we got to cardiovert him. And so we put him on Eliquis for 6 weeks. And we didn't do the TE on Eliquis. And then we did do the TE at the time of cardioversion. We started on Ridmol. We went back in atrial fib. And so we figured a drug failure. But we weren't happy with this, and we didn't think we would be able to keep him in atrial fib. And so we decided to send him for radiofrequency ablation, and so he did go for that, successful, and returned, I think, on Tickerson, and had a sinus rhythm and maintained that and was much better. And this time we did a chemical stress CMR, and so we'll show you some images. This was a big switch. So 1915 or 2015, we're off of PET scanning, and we're doing CMR. And the reason for that is that we couldn't really afford those generators. Actually, the price went up for 42 days for $2,000 for a generator. And you'd have to batch your patients. You have to do them all at one time during that 42 days. And then you'd have to go down and not do the procedure for a while until you accumulated another large batch of patients. Also, the reimbursement dropped by the federal government. And so it looked like this would be a good test for us to do isotopes, no radiations. 30-minute test if we do the fast version. Very, very special tech that's specially trained, and we have 2 good ones. And so this meant a lot of tech training and a lot of intellectual capital involved, and challenges to techs who and want to learn something new. So it wasn't the occasion of having a body flopper. And identify scar, hibernating myocardium. You do the EF at the time of stress, just like the PET scan. Much more accurate, greater resolution, great anatomy, radiologist not involved, except to read, overread if we need them for the overread for anything seen that's outside of the heart field. Doctor present for most of the procedure, stress is done in the room, chemically only, not exercise, because you would have to have a supine bicycle to be able to do exercise there, because you got to be in the machine. And so that was our, and of course you'd have to have no iron or steel. And so we have some images to show you. Let's show you those images. Hassan, you want to bring those images up? You'll have to change.
I'll give you the mouse entry.
Yeah, give me the mouse and change presenter, and I'll bring the images up. So, image, and this is called a black blood image, and I don't have the mouse yet, so let me see how I can get the mouse. So you, okay, so it's not, I'll tell you what, why don't you scroll, oh here it is, it's scrolling now. And so I'm trying to scroll with this. Let me see what happens. And so there we go, we are scrolling. And so we're going up, and now we're going to go down. Okay, and it's very sensitive. And so what you're going to see is a very thick heart muscle as it goes flashing by very rapidly. And it's all or none here. But let's see if, there we go. Very thick heart muscle called left ventricular hypertrophy. And there's the pulmonary artery where it bifurcates. There's the aorta. There's the origin of the right coronary. Or maybe the bypass graft to the right. Could be the bypass graft to the right. So you can see those. So let's see if that continues down. There's a bypass graft. This is very nice because you can see the bypasses. So let's go back again. This is in 2015. And so there's a bypass going off there. So that's cool. That's the one going over to the saphenous vein graft to the OM. So that's pretty neat. And let's see, there's the bypass going to the right, but it doesn't seem to be quite going there. And I don't see the right coronary. There's the main left. It's supposed to have stenosis. Lima is occluded. And the lima is missing. Here's the lima over here. Over here, the lima is missing. So we got taken down for, and there's the LED. Nice big LED. Here's a nice big LED. Circumflex should be coming over this way somewhere. So let's go back down this way and see if we can tell anything else, because it's important to see what happened. That looks like that right graft ends suddenly. It looks bigger than the occluded right coronary artery. So it may be there, right there. I don't know if that's the native right that's occluded, or if that's the bypass graft. Whatever it is, certainly going to the, here's the bypass graft to the right. The bypass graft to the right is occluded. And you can see a little ghost of it. I just caught a little glimpse of where there it is, right there. And then I caught a little glimpse, see that little glimpse of it going down, but it's not much contrast in it. And so that's a problem. So we got a new problem that we can see just off the CT scan, and then we see the LVH, and this is why it's not filling well. And then we can get ejection fraction and other information. Here's the left atrium. Doesn't look like there's a lot of bridge there. I'm looking at the left atrium. The right ventricle, right atrium. Don't see any big clots in the pulmonary arteries. There are protocols for doing pulmonolograms, the CT scans, and they're not used very much, but it certainly gives you low radiation. There's the aorta. So let's see what else we got over here. So I don't see any images over here to draw from. Hussein, Hassan, do you see any images over there to draw from?
The images are there, they're just they're not showing on the peak, but you can drag them.
Okay. Oh, here, you're right. Got them. Thank you. Our producer, Dr. Tariq, who helps us with all this stuff. And we couldn't do this without him. He's so great. And so let's look at the left ventricle and see how it beats. And so let's bring this image, whatever that is. I can't tell what it is. When I bring it over, I'm trying to drag it, click and drag. And let's make it move. There's ascending aorta. Hassan, maybe you can drag images over to that. Oh, there we go. Let's do an LV. See how this beats. So hopefully we should see it systole and diastole moving back and forth. And this is the inflow of the left atrium, outflow the aortic valve. And so, and I can scroll it a little bit, and you can see the difference. And there is some apical thinning, but that can be normal. So let's pop some more images over. And Hassan, if you can pop some images over for, looks like pretty contractility there. Looks like the inferior wall may be beating okay on that image. And this looks like the look locker, where we're really trying to understand. Oh no, it's the contrast study. It's the contrast study where we're looking at blood flow, and so seem to make it grow. Oh, there it is. And there's some decreased blood. Looks like over the lateral wall, where it's darker over there. And here's another picture. And so we were wondering about inferior lateral, is what we were wondering about in this patient. And the right graft is very suspicious. You want to get the some other images for me, Hassan? Okay, it's a perfusion image again. Ah, this is late gadolinium enhancement. So this is where we're looking for scar tissue. I don't see any scar tissue back in the back in the wall, because it would be very bright, and it would be also inferior wall down here. This is short axis, and so we're looking for scar tissue, and we don't see any scar showing damage in that particular area. So it looks like what we've had here is we've had occlusion of the bypass graft to the right coronary artery, and we have occlusion of the right coronary artery, and we don't have damage to the inferior wall. And so the first time he got short of breath and had some dyspneic exertion was when he developed atrial fibrillation. We solved that, and now we've got a problem where he's short of breath again and not doing well. And we're able to show that he has a bypass graft down to the right coronary artery and has some ischemia to the lateral inferior wall, but no scar tissue there. And so these are good findings. So we are trying to find what we can do to make this gentleman better. And so let's go back to the slide deck then, back to my being the presenter, and I'll get my slide deck back up again. Okay, and I'll show my screen. And now we've got Lexiscan CMR that replaced, first we had SPECT scanning, and we were doing great with that. And then and we lost the SPECT scanner to radiology, and the whole service, so we couldn't do very well at all. And we were this treadmill remote from the SPECT scanner, the radiologist, and basically there was no physician anymore, and we lost our intellectual capital in terms of very highly intelligent tech. So we went to PET scanning, had a very intelligent tech, Yale trained, and we were able to do PET scanning, and then the financial aspect changed by Medicare and by CMS. And so then we went to Lexiscan, and now with Lexiscan we're able to get quality images that are much better than you can get with SPECT scanning. And so during time, most cardiologists and most heart centers are left with SPECT scanning. And so they didn't make this evolution from SPECT to PET to MRI. They're still stuck back in 2001, 2005. They're still stuck back 11 years ago. And so, but during the same time CT evolved, the CT gave us information, and then PET evolved, and now Lexiscan is involved with CMR. And so you can see basically have followed these trends, and we're able to move that on into where we could do, and this is where we converted him, and we did CT of his chest, and we found the lesion, and we decided we were going to follow that lesion because he wasn't a smoker, but we're going to follow some node that he had, which we did, and then the echocardiogram in 2016, and then new surprise, which was an elevation of his right ventricular systolic pressure on the echo. And so this has been coming up over some time, and so we were left with that TR and some mitral regurgitation. And so I think all of this ties to what we were showing, which were the images of the problem with the right graft and right coronary. And so all this seems to be giving a new problem. So let's look at this CT. Let's see if we can get that up, and that'll be our last image. So just hold on, we're getting the CT image, because we're talking about a chronic total occlusion of the right, or at least we know it's a chronic total occlusion, and then a recent downing of the graft to the right. Then we got to understand the anatomy and what we got to do to change this. And so, and these are our images to approach that. So let's look at this and see what it tells us. And so here is our heart overall. It's a very roly-poly guy, and so it's hard to get really, really nice images because of the body factor. So usually we increase the KV, and then contrast to try to compensate for that. And so trying to move this around a little bit for you. And so here's the LAD. This is the interventricular septum. You can see some of the distal LAD there, which I flipped the heart upside down. And so we'll try to move that a little more smoothly. And actually the 3D volume rendering image is best for seeing that. So let's go over and look at the axial image. So hang on here, we'll get the axial image up. And Robert Carroll looks like has a question. So we'll get to you, Robert, in just a minute, Bob. And so we've got this image over here. Let's take a look. And we'll put the axial image up as being our dominant image here, so that we can use image-guided cardiology. And so you have seen that we've evolved during this period of time. We have evolved. Here's some calcification of the mitral annulus. And let's go through this a little bit and see how we scroll through here. And so there's a left ventricle, left atrium. Let's go take another look over here. Hang on. I'll get some more images up simultaneous. It helps to have simultaneous images to look at 4 for 1. And so we're trying to get that up, son, to get 4 for 1. Click on this little thing over here. That should do that. And so if you can click on it for me, I don't seem to be getting that image up. So what we saw was you couldn't see the bypass graft to the right. It's gone. There's a little nubbin where it used to be. And maybe I've lost my contact with the computer here. My keyboard. If you could give it a little flip there, son, that's great. And we can see what this looks like. Hang on just a second. And we can flip that around a little bit. So I think I've lost contact with the image. But the main point is that the right coronary artery is totally occluded, the bypass graft to the right, so and we're looking to see if there's something we can do with what's called a CTO. And CTO is a chronic total occlusion, and we want to open that up if possible. So our plan is that we think this is causing a shortness of breath. This is our new problem. It's a new occlusion, and we need to be able to open that up. And so that's what we're going to do, and we're going to decide how to do that. And so we did send them to the Cleveland Clinic, and the Cleveland Clinic basically looked at all this stuff, and they came up with these numbers you're aware of. They came up with this being occluded, which we came up from the MRI, and came up with information. They put a stent in the main left. They didn't bother with the right. Pretty bother the right, because I'm sure it's going to be a little tougher. So then we sent the patient with Dr. Stromquist. did report feeling less shortness of breath. He lost 15 pounds of fluid. Feelings got better. He's still having some shortness of breath. And he's a little bit anemic from the cardiac cath. So we're going to build back his hemoglobin. We have the elevated RV systolic pressure, which I think is papillary muscle dysfunction secondary to losing the graft to the right coronary artery. And so we're going to try to get his hematocrit up again, and then Dr. Stromquist is going to recath him and look at that right and see about opening up that right. Didn't show his cardiac cath, but the cardiac cath didn't show very good images of the right because it wasn't cannulated very well. And so we really can't tell you what this looks like other than 100% occlusion, and whether there are good collaterals filling and whether there's something we can go into open. So that's where we are on this gentleman, and give you kind of in a nutshell, knowing what happened to him during the period of 17 years, but what happened to us, which is even more, and how our scanning changed totally from being SPECT scanning to being a really great SPECT scanning to being terrible SPECT scanning to then doing PET scanning, and all that to do with the laws of the land, where basically because of Stark we had out of SPECT scanning, and so that service basically went, and so then we were left with PET scanning, and then CMS lowered the reimbursement, and we couldn't afford that anymore. So CMR, and now CMR is doing. So you can see all the things that evolved during the time in terms of healthcare legislature, how certainly that does affect us. And so Robert, Bob, did you have any questions? You have to unmute yourself if you do. So, that's the question panel. Can we reopen right coronary? That's what Bob said. And boy, that's you're right on the mark, Bob. That's exactly what we want to accomplish, is can we reopen the right coronary? And so you're right on the point. And that's what I want to know, and that's what we're going to figure out. And we'll give you a follow-up and actually show the images Dr. Stromquist acquires and where he can reopen that right coronary, because he's not going to do well until we're able to do that, because I think his mitral valve is leaking, his systolic pressure is up, and he has right heart failure because of that. So that's it for today. And we're going to post this on Cardiac Care Critique if anyone wants to follow up on this. And it was a great conference. I think we had a lot of information here. I hope you enjoyed it. Bye-bye.